So thanks very much, Dr. Hogg, for agreeing to sit with us and talk about your medical and research career.
My pleasure.
I'd like to start out by asking you about your early work in family medicine. Where did you first practice?
Right out of my residency, I went to a small town in western Quebec. So that would be the part of Quebec near Ottawa, the other side of the Ottawa River.
Okay.
Small town called Wakefield. It was a town with about 60% Francophone and the rest Anglophone. And there was a small 31-bed cottage hospital there.
Wow.
So it was a fantastic experience for me. I was backed up by 3 brothers who worked in practice there. And their father had been the doctor before them in that village. And he married the daughter of the first doctor.
Wow.
And who had come from a family who had just immigrated to there. So their roots in the community were phenomenal. And their dedication to the community was quite amazing. So for example, when their father, Dr. Harold Geggy, had died, they kept his house vacant as an effort to try to attract or recruit a new doctor. So when I was coming out of school, broke, it was very attractive that I got to go and live in this house, rent-free, supplied by the doctors in the community that had recruited me. So I think they would have taken anybody who had an MD. I don't think it was a coup to have, and I think I was probably the only applicant for the job, but it was very special nonetheless.
That's a great story. So you must have done a full range of work there. Full service practice?
Yes.
Then?
Yes,
Okay.
and then some.
And then some.
Yeah, it was quite remarkable. We looked, excuse me, there were these 3 brothers who by then were in their 50s, and me. So there were the 4 of us, and we were offering a service 24 hours a day, 7 days a week. And there was 1,200 square miles of territory for which we were the medical force. So, and maybe in the summers, there were many more people because it was a cottage area. People from Ottawa and other places had cottages there. But in the permanent population was about 12,000 people. So it was very busy, very challenging, times quite scary.
Mm-hmm.
And more than once I had to phone one of these brothers and say, I'm over my head here, what do I do? And they were fantastic. They would, come down to the hospital and sort it out for me.
So that must have been an incredible way to get experience.
It was
very
scary.
Right out of school.
Very scary. Actually developed a strange symptom in my chest for a few months, which had no physiological basis whatsoever. I absolutely knew it was just stress, but so yeah, I found it quite a change from residency in medical school where there's always somebody around to help. Mm-hmm. But it was exciting. There's no question about that.
Yeah. Is there a situation, can you tell us maybe about 1 or 2 patients or situations that really stood out in your mind?
Yeah, well, we have all these horror stories that we doctors love to share with each other, right? And, one was, there was no ambulance service in that community at that time. And so sometimes, we all had these 4-wheel drive trucks, and we would go to the scene of the accident or whatever. And so we were quite well equipped. Like we had this suitcase that we would just grab and take with us, so that we could really, we're quite well organized that way. And once I got a call from the Sûreté de Québec, so that's the Quebec Provincial Police, saying they wanted a doctor right away. They were sending a car. So this police car comes screaming into the parking lot, and I jump in with my great big huge suitcase, and off we go. And we went further and further away until there was actually no road. And at that point, there was a skidoo with a what do you call it?
A sled?
A sled behind it. And so then I got onto this sled, and we went about 30 miles into the woods to some, there was apparently this skidoo route that went all the way up to Val d'Or that people would go on holidays and go, Anyway, somebody had hit a tree and broken his femur and was lying in the snow, and every time they had tried to move him, he would just scream in such agony that they couldn't move him. So there I was out, in 4 feet of snow trying to split this guy's leg. And then, so I actually had some morphine, so I was able to give him some morphine, and I was scared to death that I would depress his respiration, and I'd end up having to bag him or something out there in the middle of the woods on some sled. But anyway, it all worked out, and we got him back to to where there was a road. And then from there, the police brought me back to our little hospital, but they took the patient to a much bigger hospital in the city. And about 8 months later, I was sitting in the office, and one of the staff members said, I think I need to interrupt you, and I don't think you're going to object. I think you're going to want to see this person. So I go, okay, well, I don't know what this is about, but okay. And it was this man who had broken his leg, and he had been discharged from the hospital that day. So this was like 6 or 8 months later. He had suffered a stroke from the fat inside the bone marrow from this very, very severe fracture. Something that can happen, a terrible complication. So that's why his recovery had taken so long. And that was the day that he was allowed to go home. And he wasn't from our district. He was from some hundreds of miles away. But on his way home, he came up to say thank you. So that was a pretty special moment. It was quite a remarkable community. People were very grateful to have a hospital. And so there was all sorts of fundraising and assistance to, to keep, to equip the hospital. And so it was a great privilege, really, to be there. It was hard work.
Yeah.
But
a
very
real
special.
community hospital.
Oh, yeah.
Wow.
Yeah.
That's great. So how did you get into research?
I think that the sort of curiosity was probably embedded as a result of growing up from my parents. But in terms of medical research, I had, when I was accepted to McGill Medical School, and my parents lived in Montreal, so I went back to Montreal and was looking for a summer job, and I found a job in a research lab helping out. And then subsequently, as a medical student, I was employed to go back in the summers to work in that lab, and that I think was quite had a large influence in my interest. Then when I got to this, I actually took the job in Wakefield because I wanted to learn how to speak French better. And my wife was completing her law studies, doing her articling in Ottawa. And it was possible for her to commute to Ottawa and do that. So we thought we were just going for a year when we went to Wakefield. And my main objective, I think, was to learn to speak French properly. But then we fell in love with the place and we stayed there for 15 years. And shortly after I was there, the Quebec government, which was from a long ways away in Quebec City, decided that they should close the hospital, that they couldn't understand why a village of 500 people had a 31-bed hospital. That seemed like a lot of beds for 500 people. But it was retarded, right? I mean, we looked after 12,000 people. We looked after this huge, sparsely populated rural area. Mm-hmm. So it was just the way they did their arithmetic that they didn't understand what they were saying. And so the hospital came under threat, and everybody in the community was responsive to this threat. And I was pretty new, and one of the ways that I could assist was to use the skills I had or the training I had had as a researcher to try to collect some information to show how foolish it was for the government to think they should close the hospital. So it was well, to give you an example, one of these brothers that were my partners, the oldest one, whose name was Hans Geggy, was the mayor of the village and the surrounding area. And I was very concerned that the government was going to close the hospital. And he was quite sure they would not. And so I said to him, why, how can you be so sure? And he said, well, we're going to get the mayors from every municipality within, 100 miles to write, to go to their councils and to pass motions saying that they mustn't close the hospital. It would be a big mistake. And I said, well, how do you know that they're all going to do this? Because there had just been a mayor elected in the nearest village and biggest village that was this was in 1976, and it was when the Parti Québécois had just been elected, and this particular man had been very vocal about separation. So I thought he might not be sympathetic to the hospital because the doctors had more of an English background although they were fully bilingual. So he said, oh, no, this man they'll write they'll do this. I'm sure they will. And I guess I was worried enough about this that I asked one more time. So he says, well, I'll tell you a little story. So when these boys grew up in that village, their father was the doctor. There was no hospital. And the guy who had become a mayor had, when he was 7 years old, had acute appendicitis. Mm-hmm. And they were poor as church mice, apparently. And when his father brought him to the doctor in Wakefield, it was quickly realized it was appendicitis, and they had no hospital. They couldn't possibly deal with it there. So he took him on the train. There was no road. So the doctor took this little boy on the train to Ottawa, found a surgeon who would operate on him for nothing, and then brought him back and nursed him back to health in his own house until he was ready to go home to his family. So he kind of told me this story, and then he said, so don't worry, I think we've got some favors we can pull in here. And they did. The fonctionnaires, the bureaucrats from Quebec City came to have a public meeting to sort of talk about what would happen if and when the hospital was closed. And from a permanent population of 10,000 people, there was something like 3,000 people showed up at the meeting. It had spilled outside, there was no building anywhere near close to that. Mm-hmm. And the bureaucrats, by the time they had to walk through this crowd to get into the church and address the crowd, they were backpedaling, saying there was no way they were going to close the hospital. So, but in the meantime, I had done I guess probably my first study, which was to go to a randomly selected group at homes throughout the territory and ask, where they had received their medical care last. And one of the questions was, had they ever done anything, any volunteer work or donated anything to support the hospital? And 80% of the people in the district had done something to support the hospital. So it was very special. It had a central social role in the community. Mm-hmm. And we were able to demonstrate to the Quebec government that in fact they would lose money if they closed the hospital. So I think it had a role in sort of that important decision for the community. So that I felt somewhat emboldened by that. I think that got me, encouraged me to continue. Wow. Of course, a small little place like that is a fantastic place in which to do research. And if you look at the history, going back a couple of hundred years, some of the really remarkable findings that were done by family medicine researchers took place in somewhat isolated communities because they just had more control over what was happening. Because basically people don't have a choice. It's somewhat of a medical monopoly. Okay. And so your patient list is the same as the phone book, right? It's everybody. And whether they like you or not, they don't have much alternatives. So, and with respect to infectious diseases and things like that, it was possible there was just more control mm-hmm. when it was a somewhat isolated community. So the opportunities were phenomenal to do things there, and they just, I was drawn to them like a moth to a flame.
That's great. So what were some of the other areas you studied? I understand you did some study in obstetrics in Wakefield.
Yes, again, that was prompted by the fact, every hospital has to be accredited. Okay. And so we had our accreditation visit, and they sent a pediatric neonatologist to accredit our 31-bed cottage hospital. So this physician specialist had come from the Hôpital Saint-Justin, which is the huge children's hospital in Montreal, and he got to have a nice little drive out into the country and accredit our hospital. Not that he knew the first thing about family medicine. And when he realized that we were delivering babies in this hospital, he was just appalled. He thought, this is wrong. So in his report, he recommended that our obstetrical service stop. So we, in our hearts, felt that this was going to be a big mistake. It was extremely stressful to be doing obstetrics in a small hospital like that. Mm-hmm. You get into trouble, there's no one to help you. So, and we only delivered about 40 babies a year. So it was, there was a tremendous amount of effort for us to provide that coverage and, try to take extra training and so on to be competent. So we were heavily invested in it, and he just dismissed it like it was stupid. So we thought he was probably wrong, and I was able to find some papers that had been published that showed, in fact, that he was wrong, and that when you take away obstetrical services from a community like that, that infant mortality goes up quite dramatically. So even though it's not perfect, it's better than nothing. And there were some quite remarkable studies that demonstrated this to be true, where entire jurisdictions were, like the entire country of New Zealand, for example, they were able to map where people lived and where they received their care and what happened to the baby. So so they took away the issue about referrals, because the initial studies that had showed that it was safer to deliver in a small unit were criticized by people saying what is happening is that you are accepting these women, you do a poor job looking after them, they get into trouble, and then you send them to a bigger unit, and the bad results are attributed to the bigger place to which you transferred them. So they had to get around that by attributing the death, the neonatal death, to the place near where the woman lived. And once they did that, they showed that it was still the case that it was safe, in fact safer, to live near one of these small places, which is quite amazing considering the population is more poor. And there were more Aboriginal Canadians delivering in situations like that, and other people from disadvantaged backgrounds. So this man from Saint-Justin Hospital was wrong, and we were able to do a review, a systematic review of the literature which showed it. And then we had to travel to Montreal with the chair of the board of directors of our little hospital and face down these people at a meeting with the licensing authority in Montreal. And to their credit, they recognized that they had made a mistake, and we were allowed to reopen our service. And we published it in Canadian Family Physician. And then I started getting phone calls from people in small hospitals all over Canada. It was quite amazing, the number of people who were being threatened the same way. And so that was very rewarding. They actually changed the policy for the province of Quebec.
Good. So the small community hospital won out.
Yep.
Is it still open today?
They've built a new one.
Oh,
Yeah.
good.
It was a cute little manor from a very wealthy family that had built a sawmill, a logging sawmill there just as the country was being opened up. So, and it had had some additions and things to it so that it was, had 31 beds. But it was, it could easily have been condemned from a fire perspective or something. So it's, I think, the only hospital that's been built in the province of Quebec in the last 40 years. So they didn't, not only did they not shut it down, they replaced it with a brand new one.
Wow.
So, yeah.
That's a double victory for you and your team.
Oh, lots of people were involved, absolutely. But what made the difference was we did a study. I mean, it was so easy to do things there because there were only 4 of us, and at one point 5. And so if I would, with a colleague, dreamt up an idea, we just had to sort of convince one more person, and we had the majority, right? So decisions were made very quickly. And we did a study that showed, well, when the bureaucrats came from Quebec City threatening to close us, they backed down right away, but they didn't back down all the way. They said that they were going to study this, and in the subsequent 5-year plan, it might happen. So at this point, we had time to prepare. So one of the things we did is we had the physician fill in a form after seeing every patient in the emergency room. And we asked, one of the questions we asked was, if this hospital had not been there, would the patient have died? And so that was a good way to ask the question, because the amount of time it would take to go to the next place depended on the weather,
Right.
and the road conditions and so on. So anyway, we figured out, I can't remember the actual numbers, but they're, say for the sake of argument, every 6 months, 10 people would have died, something like that. So even if it was just a couple, it was important, right?
Right.
So we presented this data to the Quebec government, and it was just dismissed as meaningless, because they said that everybody who was collecting the data had a self-interest in exaggerating the value of the hospital. So, the fact we had scales and had tried to do it very rigorously, they didn't matter. But we had also done a different study, which was a costing of what the cost was of keeping the hospital open. So it was a small operation, and everybody did, like the nurses, if they weren't in the emergency room, they were assisting with the delivery of a baby or looking after an inpatient, so it was incredibly efficient in that way. And the per diem costs were the lowest of any hospital in Quebec. So that was what it cost to look after somebody in that hospital.
Okay.
If we didn't look after them, a quite substantial percentage of them would have had to go to Ottawa in a different province and be hospitalized. And the arrangement that the Quebec government had with the Ontario government was to pay the average cost of a day in the Ottawa hospital. So we would have been sending the sickest people and being charged the average cost. Is that how it worked? Right, so that's what was happening then. So the status quo was we were getting charged the average cost to look after the sickest people in our population when they were transferred. So that was a huge plus for the Quebec government, right?
Right.
And if they had had to send everybody, that whole situation would have collapsed, and they would have had to pay the real costs. So it didn't make any difference to them whatsoever that people might have died, but they were very impressed with the fact it was going to cost them money if they closed the hospital. So it was quite a cynical arrangement, but they not only didn't close the hospital, they built a new one.
Yeah.
So
The power of
Yeah.
the power of numbers, I guess, really speaks.
Yeah, so the research was very applied and very practical. And it did make a difference. And as I say, it was a way that I could contribute because I didn't have the lineage and the history that my partners had. Them having been born there and gone to school with everybody, and they were in a far better position to sort of mobilize the community politically.
Right.
So it was a way that I could help.
That's amazing. So after that, you started to expand your horizons in terms of research. Is that correct? You went into health services research? For a whole series of reasons, I had to, family reasons primarily, had to leave Wakefield after 15 years there. And I was recruited to go to the University of Western Ontario and and they permitted me to take their Masters of Clinical Science course there, Okay.
which gave me some more formal research training. And after I completed that, I went to the University of Ottawa Department of Family Medicine, where after a few years it was recognized that I was drawn in this direction, and I was very generously given some protected time when I was not involved in teaching or seeing patients, and able to pursue my interests in research. And that coincided with just the beginning of opportunities to get funding, to get grants.
Okay.
And so we were able to get some funding to do some work. The first main project for which we got funding, where really I was partnering with Jacques Lemelin,
Okay.
who also had come and joined me in practice in Wakefield. So I'd known Jacques from medical school, and then we ended up working together most of that 15 years in Wakefield, and then together eventually ended up in the same teaching unit at the University of Ottawa. And we had an idea about how to assist practices, community-based practices, to improve the quality of care they were giving. And we felt that that the attitude was good. People wanted to do a good job and they wanted to get better, but it was pretty difficult to do it and practice all at the same time. So it was, the metaphor being, it was a little bit like trying to fix or improve a wing on an airplane while it was still in the air. So we had this idea that we needed an external person to come to the practice and assist us in our efforts in our quality improvement efforts.
Okay.
So this approach is now called outreach facilitation, and we worked away at it, came up with a coherent plan, and we got some substantial funding to hire 4 nurse facilitators, attach them to a whole series of practices that were randomly selected either to get this assistance or not.
Mm-hmm.
And we were able to show that the practices that had the assistance of a facilitator were able to improve the quality of care they were delivering compared to those that didn't have the same opportunity. And we were able to show that not only did they improve the care, not only did their performance improve, but the government would save money because of it. So there was a lot more preventive medicine, preventive services delivered, more flu shots given to people at risk, for example, and so on. And that meant that there would be fewer trips to the emergency room by these people, fewer hospitalizations, and so on. And we calculated the costs and were able to show that there was a return on investment within 1 year to the government, if they paid for this program, of I think it was 35% or 40% or something.
That's an incredible amount.
So they would recover all the costs of paying for these facilitators and all the costs of the extra flu shots and syringes and everything else, and pap smears and mammograms, and there's a whole suite of preventive maneuvers that more of which were done. So that was published, and not surprisingly, there was a fair amount of interest, because it's not often that you can improve care and save money at the same time.
Mm-hmm.
But this one really appears to have this quality dividend. So governments were very interested, and a little bit at a time, more and more facilitation programs began to start up, until really there are lots of them now.
Okay.
We continued to do a whole program of research in this area, addressing whether the changes or whether the improvements were sustainable, and things like that. And we're very gratified that just a few years ago, when the United States government passed what is now commonly called Obamacare.
Okay.
That law passed by law now. The United States is about to put a permanent outreach facilitation program in every district in every state.
Wow.
So there's potential to improve by around 11 or 12% the quality of care that's delivered, and that potentially could happen to hundreds of millions of people. So that's an example of the leverage that research can provide. You know, you can work hard, and it's incredibly important and rewarding work to practice looking after your own patients. But when you get lucky and you discover something new that allows things to be done better, it has the potential to impact many more people than that. So I think that's the draw that is addicting, really, to a researcher.
Right. Yeah. So that you've just told me two incredible stories. What are some of the challenges for research up in the past, say, 30 years? The challenges for family medicine research, and what will be the challenges coming up?
Over the last 30 years, primary care research, not, even, speaking more broadly than family medicine research, has received less than 1% of the funding from the Canadian Institutes for Health Research. So the biggest challenge has been getting money to do the projects. I mean, it's there, and if you're persistent enough, it's been possible to get it. But we have had a very small community of researchers, and most people have, I think, found it to be quite a struggle.
Right.
It's a lot of the work seems to happen, on Friday night when you're on call and things are quiet. You can settle down and, we used to have to sleep at the hospital when we were on call. So, if I had my work finished by 9 o'clock or something, there was no way I was going to go to bed. So, you could work on your scholarly work at that point and so on. But it was very much fit in after.
Stolen time.
Yeah. And so the number of people who were prepared to do it, was limited by that. I don't think that we had the same training opportunities that people have today. It was, I think, sufficient for that time because we didn't have to, it wasn't as complicated. But now, I think, people need to understand and choose this as a career and sort of go for it earlier on. You can't just sort of transition to it from being a full-time private practitioner into a professional researcher in mid-career, I think, as easily today. There's so much more complicated things to understand in terms of the analyses and the accessing health administrative databases and ethics and so on. So it's a far more complex environment today. Fortunately, there's been, there's a lot more money available today than there was then. And there are even, training awards and career scientist awards and things like that.
Right.
So it is possible today for a university department of family medicine to support a small cadre of researchers and not and recover the money, essentially. We have an opportunity right now. We're really in a sweet spot. The CIHR, for example, does recognize that they made a mistake and they did not build the necessary capacity for primary care research, and they have not been sufficiently supporting it with grants. So they have a number of special programs to try to remedy this situation. So times have never been better, but we have to produce. Otherwise, we'll be right back where we started. So I think those are the challenges.
Okay. Let me see. So could you tell me more about, you're going to cut that part out, aren't you? Some of the things that got us to the opportunity with the most recent opportunities and the growth in funds for primary care and family medicine research in the country. A lot of stuff has happened among the researchers, mobilizing and doing further studies in health services and policy and those different areas to get us there. And I understand you and a number of other family medicine researchers have recently mobilized, created the Canadian Primary Healthcare Research and Innovation Network.
Yes.
Can you tell me about the goals?
Yes, this network is now just a year old.
Mm-hmm.
The Canadian Institutes of Health Research has said that it is going to support a SPOR network, SPOR, Strategy for Patient-Oriented Research.
Okay.
And this will be $25 million over 5 years with the possibility of renewal to sort of coordinate primary care research across Canada. Not only to, so there are a number of responsibilities for a network like this. One is to coordinate, and so that the efforts of the widely dispersed researchers across Canada from different disciplines and in different universities and so on is more, so that their work is more efficient.
Okay.
So that's a relatively straightforward task, I think. Another is to build capacity in research. And a third is to actually conduct large research studies that really need, to be in multiple jurisdictions, potentially even connecting internationally.
Okay.
So the CIHR has determined that a network would really help build capacity and mobilize the primary healthcare research community, and has challenged our community to get its act together and come together and demonstrate that we would be worthy of this investment of $25 million. So there's a group of us that are working to try to earn that trust from the CIHR. So what we've done is we've just set about trying to do it. We're doing it with very little money, okay, but we are doing it. So we've managed to, create a website and a strategic plan and a stakeholder advisory committee, and so on to try to, and we've done a lot of thinking about, how we would spend the $25 million so that we can get the biggest impact possible from that investment.
Right.
So we may end up competing in a sort of traditional competing mode for the opportunity to do this, or the CIHR might look for a more cooperative way of trying to get everybody to come together. But whatever, we are positioning ourselves to be part of that.
Okay.
And we've produced a coalition. The first two organizations to seriously support it were the College of Family Physicians of Canada and the Canadian Nurses Association. And not just by, encouraging us, but by giving us money so that we could hire a person to work on this and begin to, pay for a website and create a, use social networking to sort of begin to connect people.
Mm-hmm.
So it's been very gratifying.
virtually everybody we've had the time to approach has agreed and given us, modest amounts of money so that we can begin to operate this network. So we have the Canadian Medical Association, the Canadian Pharmacists Association, and occupational therapists and chiropractors and all the kinds of professional associations which represent the disciplines that work in primary health care. So that's been special. And not only have they sort of, lent us their moral authority, but they've really participated too. So we have, every 6 weeks we have a teleconference where we sort through, the policy issues, just just how well we interface with the pharmaceutical industry and all sorts of complicated subjects like that. So how we will govern the network and so on. So there's no doubt that this, the Canadian Primary Healthcare Research and Innovation Network has come together as quickly and as well as it has because of the promise or the possibility of this $25 million investment. That's been the catalyst. But having got us started, it's totally amazing what is possible and what an important role a national or a pan-Canadian organization can play in terms of assisting people with an interest in primary healthcare research. It's quite remarkable. And even this, embryonic organization has already been able to connect Canada to a study that is happening in 35 other countries in the world.
Really?
So we now, in most and conceivably all Canadian provinces and territories, are participating in a study which measures and will compare the performance of the primary care systems in all these different contexts and countries. So that could be quite useful in terms of, improving our understanding of how well we're doing, allowing decision makers and governments to improve their decision making and their, resource allocation decisions and so on.
Exchange of ideas and so on.
Yeah, it's quite magical actually to see what's possible.
You've been a big supporter of interdisciplinary collaboration. Talk to me about why is interdisciplinary so important?
I think there's sort of two levels of here. One is interdisciplinary research collaborations. So that's having researchers from different backgrounds working together. I think there's very good evidence that there's more publications, more impact from research teams that have done that. I don't think there's the slightest doubt. And the funders are now mandating this. So it's, totally, I guess, kind of obvious now that it's been proven. But, if you have a health economist on your team, you can do things that a bunch of doctors can't ever manage to pull off by themselves. So that's very clear. And it goes beyond that to including, political scientists and anthropologists and things like that. So it's very clear once you do it. There's some investment in energy because people have, different ways of using language and different traditions. So you have to be a bit careful about things like attribution of academic credit and things like that. It's often done differently in these different disciplines, but it's absolutely worth every bit of the effort. And the other sense of interdisciplinary collaboration is seeing the provision of primary care services as a team effort. And that's clearly the way the world's heading. There's more and more evidence that the quality improves when that happens. But it is a huge, it's not been adequately studied. We don't know, in what circumstances, for which patient populations, what's the best team composition, and so on. So there's lots more to sort out there, but I think that direction is firmly established now. And so as an object of study, it's an important area for us to be studying, and in terms of our approach, using, teaming up with colleagues from disciplines other than the one we're in is very rewarding as well.
Okay. What are the chief challenges for family medicine and primary care research in the next 20 years?
Well, in the shorter term, it's to make good on the opportunities that we have. I think it's very important that we deliver. The people, the people who are totally focused on basic laboratory kind of research are watching and will use every opportunity to lobby that they should be getting the money instead of us. So I don't think we'll get a second chance if we fail this time. The other challenges, one of the things that is really revolutionary is it's all because of computers and the ubiquitous and now fairly low cost of computing. So there's enormous potential to merge data sets and to so I think that getting better and better at exploiting health administrative data sets has tremendous potential. And just last week in the United Kingdom, they announced that they're changing a whole law in their parliament to bring a full copy of the electronic medical records from the majority of their general practitioners and merging it with their health administrative data sets. So that's going to be phenomenal what they're able to do with that.
Wow.
And so very, very exciting potentials, lots of complexity there in terms of protecting patient confidentiality and privacy. So it'll be quite specialized work, but the payoffs will be enormous.
Okay. What advice would you share with somebody who's considering a career in family medicine research or primary care research?
Well, I think they have to be quite serious about it. Dabbling probably isn't going to work.
Right.
So I think there's a price to pay. I think it's not possible to stay as a full-service clinician and be a productive researcher. It would be very exceptional to be able to do that. So, a person would have to consider giving up their involvement in obstetrics or their regular shifts in the emergency room or those kinds of things to kind of diminish the extent to which they're involved clinically. It's not really likely that a person can be competitive working, Friday nights between calls and things like that today. And I would think that people should be encouraged to seek additional training as well.
Okay.
I think it's just become too complicated, really, to sort of manage it on your own. So even a PhD would probably be a good idea if it's a young person that's interested in this and they have that opportunity. They should go for that level of training, I would think.
Make the commitment and follow it through.
Yeah.
Okay. If there's something you would have done differently in terms of your research career, what might it have been?
I don't spend a lot of time looking backwards. I had a very particular circumstance that was difficult, and that was in the Primary Healthcare Transition Fund. I submitted a whole series of grants, thinking that I found the whole process a bit serendipitous. Couldn't really, I mean, there had been times when I had really felt I'd put in a grant that was my best work and it would be trashed by a reviewer, and other times I almost was embarrassed to put something in. I hadn't really applied myself to it well, and it would be funded. So I found the whole thing kind of mysterious. So my response was to just sort of blanket this competition with a whole series of projects, thinking, well, maybe that I would get one. But I got almost all of them. And so over a period of about 3 months, I got $20 million of research funding and had to hire close to 100 staff to run these various projects. And that was substantially over the top. And I think we made some mistakes in our hiring, and in our, we were having to create everything from nothing. And I certainly didn't have experience being a manager like that. Mm-hmm. So if that had happened a little more gradually, that would have, I think, been better.
Thanks very much for speaking with us.
Oh, you're most welcome. Thank you.